Hello everyone, this is Dr. Cosby. I am excited to be finishing up our final segment of lumbar sacral spinal pathologies. And this is part 4 of a 4-part series where we'll be talking about very specific pathologies that plague the lumbar spine in particular. As you might recall, the lumbar spine represents the spine from L1 all the way to L5. But we certainly should include the T12 vertebral body since it articulates with L1 and the S1 vertebral body since it articulates with lumbar spine number 1. Our first pathology is going to be spinal stenosis. So spinal stenosis doesn't happen very often in the age population that most of you all will be working with, but the reality is some of you want to go on to become a physician assistant or maybe even a physical therapist, at which point in time you'll be exposed to patients over the age of 50. So spinal stenosis is most often, as you can see it, an upper age pathology, but that doesn't mean you won't see it in athletes. So as we think about the etiology of spinal stenosis, it's a narrowing of the intervertebral foramen or the spinal canal. In other words, the way that I would say it is the space through which the spinal cord is able to run, right? So it's a narrowing. Most often when we think about spinal stenosis, the things that are going to be responsible for that are going to be slow degeneration of the vertebral body, which kind of creates what we call our exostoses. And those exostoses then create kind of these bony segments which protrude into the vertebral canal, compressing the actual spinal cord itself. And then in general with aging, we just have a collapsing of the actual disc space. But the real causative factor most often, unless it's a disc occupying lesion such as a tumor or cancer, one of the real reasons that we see oftentimes stenosis about the spinal cord really has to do with this right here. You can see this little white space here impinging upon the spinal cord, right? This is normal white spinal cord, very beautiful. What we can see here is an osteophyte formation or an exostosis of the bone which then starts to protrude or impinge upon the spinal cord. So in terms of the signs and symptoms that a patient is going to present with, they're going to have pain during walking because we know that there's going to be increased load to the lumbar spine area and then indirectly going to place more pressure on the spinal cord via that osteophyte formation. Weakness distal to the insulting area. So example, if the osteophyte formation and stenosis is occurring in L4, then you're going to have weakness in L4, L5, S1, S2, S3 nerve roots, if that makes sense. So weakness below that. You're going to have radiating pain, numbness, and tingling, or what we would call is radiculopathy. So if I could summarize this, I'm going to say we're going to need to do a lower quarter screen on patients who report to us and have pain with walking, right? Other things that we see most often is the patient will report, because it's actually impinging upon the spinal cord, that's a centralized injury, right? So oftentimes they're going to report bilateral buttock or leg pain. They most often report relief when they're actually seated, because that's going to take some of the impingement off or remove the osteophyte from impinging upon the spinal cord. They will love spending time in a forwardly flexed position, and they might often widen their gait, so they might have a wide base gait. Those are all things that are going to kind of relieve the symptoms. So again, as you're watching them walk into your clinic, you want to be watching their gait. You want to be watching, are they hunched over, because that makes the stenosis feel better. There are times, however, I said bilateral symptoms, so I said bilateral buttock or leg pain and even radiculopathy. There are times where maybe that osteophyte progression or that space occupying lesion isn't large enough to impact the entire spinal cord, and so they might only have unilateral pain, and so then that would be nerve root stenosis, right? But if they have bilateral symptoms, then that's obviously going to be central canal or spinal cord compromise. So let's take a look at this, right? As we think about a normal vertebrae, one of the beautiful things about this is we can see that spinal cord moving through the vertebral canal here, and there's a little bit of space for that to happen. What happens over time is either you get degeneration, which causes osteophyte formation, or an exostosis within the actual vertebral column. So you can see that here, and those start to impinge upon the spinal cord, creating either maybe one side approach, so one side neuropathy, depending on if the osteophyte formation is greater on one side than the other, Or if it's impinging directly on the spinal cord and not at the nerve root, then you'll get bilateral signs and symptoms. This is a great image because you can see how the nerve roots will come out of each spinal level. So you can see how just a peripheral nerve root can be impinged, or how the entire spinal cord can be impinged. The historical question that you're going to ask is really one of what does your radiculopathy look like, or how are you experiencing any numbness and tingling? And they describe that as yes, only on my right side, or yes, now that you mention it, both on my right and left sides, right? And that will be a telltale sign of whether or not that's peripheral nerve or whether or not that's spinal cord. So that's worst case scenario. This is going to be long-term treatment for this. Oh man, it depends. Sometimes you have to surgically go in and intervene and shave off that osteophyte formation or remove the tumor, etc., that might be causing the spinal stenosis. But if it's in our older patient population, that's just the progression of life, right? So don't get old, I guess. Okay, next is intervertebral disc syndrome. We know that oftentimes we can, as we get older, our intervertebral disc will degenerate just in time, and that's as a result of loss of water from the nucleus pulposus, right? We talked a little bit through that in the anatomy slide. You can either have decrease in the amount of protein content, or even sometimes what we often see is there is an altering of the chemical structure. We talked a lot about nicotine. Remember I said that, how you have kind of less blood flow going to the actual disc, and as a result it just changes the chemical makeup of the actual disc itself, right? Now there are certainly those biomechanical changes that happen with the aging process, which then increase the amount of water being lost. But ultimately, when we think about patients who walk into us, younger patients who walk into our clinic, most often the etiologies are going to be listed here. I would say 6 times out of 10, most often intervertebral disc syndrome is most often caused by poor posture chronically. And so we can think about that from just a classroom perspective. If we're sitting in class and we're sitting in poor posture, remember we talked about the neck being forward as we're looking at our computer, or the neck being forward as we're texting, right? Those are all, that is one way to increase load within the actual disc, leading to a loss of water content, for example, with age. The other is faulty mechanics. So excessive flexion and rotation moments have been linked to increased risk for intervertebral disc syndrome, or the development of some type of disc pathology. Lifting heavy weights and squatting improperly, which is why a lot of places that hire individuals to lift, even most athletic training jobs now, will require you to have proper squatting techniques. We call those ergonomics. So they'll train you in the ergonomics to avoid faulty lifting mechanics. And then trauma, right? So a violent twist with a flexion moment will oftentimes increase the load in the disc and cause disc pathology. So you can see this is a flexion injury most often. In terms of the pathoetiology, you get a degeneration of the annulus fibrosus, and that degeneration can obviously occur from microtrauma, or it can occur from a traumatic episode, such as, remember that flexion with rotation, or heavy lifting that places a massive load on the disc, or disc just dehydration, right? And ultimately what happens is, if we have compromise to the annulus fibrosis, then the nucleus pulposus is allowed to kind of herniate through that process, or extrude through the annulus fibrosis. And we're going to talk through a kind of levels of disc herniation in a few slides, but bear with me because I'm going to talk about disc pathologies and then sciatica, and then I'm going to show you the levels of disc protrusions that can occur. And signs and symptoms of disc syndrome in general, they're going to have radiculopathy. So radiculopathy is really any disorder of spinal nerve roots, right? Most often, however, the nerve that is most often impacted in an intervertebral disc syndrome is going to be the sciatic nerve, which is why we'll talk about sciatica next. But knowing that sciatica can be caused by, so sciatica, any pain, numbness, tingling affecting the distribution of the sciatic nerve. That sciatica can be caused by multiple things, right? So one of them is a disc herniation, right, where the annulus fibrosis is compromised. You have protrusion of the nucleus pulposus, which maybe impacts either right or left peripheral nerve, and that peripheral nerve most often is going to be the sciatic nerve. When the disc protrudes, it causes sciatica, which is a symptom, right? So I'm going to click to the next slide where we'll see sciatica. Sciatica in general affects 40% of the population in their lifetime. So 40% of you sitting in our room will at some point in time suffer from sciatica. Now, as I mentioned on the previous slide, there are multiple causes of sciatica, right? One of them being herniated disc, which we just talked through. The other is stenosis, right? So an example would be if the stenosis is low enough in the lumbar spine, if the osteophyte formation or the space occupying lesion compresses on the spinal cord, it will irritate or cause irritation to the sciatic nerve, right? We learned in lower extremity that the sciatic nerve can also be impinged as it comes off of the lumbar plexus into the gluteal region, can be impinged by the piriformis, right? And that's in a very small subset of patients. And so you can see that sciatica is a kind of catch-all term that really makes us have to be detectives, right? In other words, we're going to have to figure out what is causing, what is the reason that we're seeing the sciatica in patients. So it's a symptom, but it doesn't name the actual pathology, right? Sciatica in general can include signs and symptoms such as a dull, achy, sharp, radiating, tingling pain that will travel. And so here's the deal: it can travel and stop in the hamstring region, right? That would be like real true sciatic nerve, but then it can also progress either laterally, right, as it kind of branches off into the common fibular peroneal nerve, or it can be more posterior into the gastrocs in the foot with the deep or with the tibial nerve, right? So we can see how sciatic nerve, depending on where, at what level it's actually impinged, can certainly have implications for the type of radiculopathy. So asking where the radiculopathy stops is also going to be extremely important, right? We know about sciatica is, at least with the hip, that the sciatica or the symptoms are increased when the hip is placed into a flexion moment, because you're going to place tension on the sciatic nerve, or you're going to stretch that sciatic nerve. Now, I mentioned the disc, and I mentioned like with age, the disc begins to dehydrate. And then in a previous slide where I talked about cigarette smokers, I talked about how it causes vasoconstriction of the vertebral blood vessels. And so as a result, there's less blood to the area. And so the discs start to dehydrate or start to shrink, right? So now I'm bringing it home here in this image or the slide. You can see these vertebral blood vessels really wrap themselves around the vertebral body, right? We can see that there. But then also you can see that they also put their little fingers or slips into the annulus fibrosus, and then also the subchondral plate, and then directly into the annulus fibrosus. And indirectly, because the annulus fibrosus is healthy and is fed and has blood flow, then it can maintain its shape and its integrity, and that nucleus pulposus isn't allowed to break through, right? So anything that would compromise blood flow, whether that's a direct blow to a vertebral body, whether that's a chronic smoker who's smoking nicotine, we have vasoconstriction, so less blood flow, right? Anything that would compromise blood flow would impact the disc itself. And you all might be saying, why am I talking about that? Because on this slide, what I want to talk about are stages of disc herniation. So that first stage is what we call disc degeneration, where we have some chemical changes that occur. Those changes can be associated with aging, can be associated with a lack of blood flow to the area, but ultimately what happens is you have a weakness that now happens to the annulus fibrosus, which allows the nucleus pulposus to to change its shape, right? Now we're used to kind of having that kind of circular or ovular nucleus pulposus, but we can see that it's kind of protruded out just a tad bit, right? That would be stage one. Most often in this stage, your patients might report some low back pain, but no radiculopathy at this point in time. In a prolapse or a stage 2, we can see that the disc position actually changes. So that nucleus position actually changes. And so it starts to cause a bulge, and that bulge will start to impinge upon the spinal canal, right? And this is what we call a disc bulge per se. Like if someone says, I have a bulging disc, this is what they're referring to, which is a prolapse disc, where you can see the actual visible bulge, and that's starting to progress onto the vertebral canal and is starting to press on the actual spinal column itself. And then this is where we start to see radiculopathy, or at least some type of nerve signs and symptoms. Now, these last two that I'm going to talk about, extrusion and sequestration, are extremely important. So extrusion, what that means is it's extruded or has really broken through the annulus fibrosus, which you see here, but it does not go through the actual spinal canal. So we've actually ruptured the annulus fibrosus, but when we bring the body back into a centralized position, that nucleus pulposus will go back to its centralized position, right? In a sequestration, essentially what happens is not only does the nucleus pulposus break through the annulus fibrosis, but we can see that it's starting to leak into the spinal cord or the spinal column, which increases the risk for systemic infection, right? Which increases the risk to actually drain the nucleus pulposus completely from the annulus fibrosis. This fluid that's allowed to sequester essentially can start to build up in the lumbar spine. It may create in and of itself a quada equina. At this point in time, you'll have neurological signs and symptoms with this particular patient. The only way really to kind of differentiate between the levels is really to refer out for an MR. So let's talk through different special tests. We will do these in the lab, right? But we really want to do anything that increases pressure on the annulus fibrosis, right? Because that's going to give us the signs and symptoms. In the upper right-hand corner, you have the straight leg raise. So this is the straight leg raise. So you're flexing that hip. And you can see with flexion, remember we create tension on the sciatic nerve. So when we raise that hip and flex it, one of the things that you'll see is the patients will report neurological signs and symptoms if in fact the sciatic nerve is involved. And then this Valsalva's maneuver, you can see the patient's making a fist and is blowing. This will increase pressure within the actual vertebral canal. And we can keep going down this list, and I don't need to describe each of these to you because in lab we're going to do them. But essentially what we need to do are these particular tests to rule in or rule out a disc pathology or sciatic nerve irritation, right? In general, though, when we think about the signs and symptoms of a patient with some type of disc degeneration or herniated disc, they're going to have some type of regional pain or spasm. That is because your body does this thing called pain spasm, pain cycle, where it's going to work to protect the area that is irritated. They'll have radiculopathy or radiating pain and paresis. Paresis is, anyone know what paresis is? Anyone want to tell me? Great. Paresis is basically, when you think about it this way, paresis is paralysis on one side or both sides of the body. So they will have paralysis distal too. Again, if it's both legs that are paralyzed, then you're thinking cord. And if it's one side, you're thinking peripheral. Now, by paralysis, I don't mean they won't be able to move their limb at all, but they might have more difficulty doing that because the sciatic nerve is irritated. I talked about positive neural tension tests, but what this means is if they have positive neural tension tests, so that straight leg raise or the bowstring test, which I don't see listed here, I guess this would kind of be a bowstring test. That means the pathology extends past the annulus and through the posterior longitudinal ligament. So again, very key concern and will drive treatment decision making. As we look at lower quarter screens, the patient will present with both patellar and Achilles tendon reflexes that are decreased. I'm going to go back here. If they're in the extrusion sequestration part of the disc degeneration phase, they will have altered dermatome sensation at the level of nerve root injury, and they will have altered myotomes most often. Remember, strength is usually 5 out of 5, so anything less than that, and that's going to be a positive test. Again, we will go through all of these special tests in lab. So here is an example of an L5S1 disc herniation. So you can see here the disc herniation is shaded in purple, and you can see how it's protruded through, right? And as we look through the spinal cord, we can see this is probably going to be a grade, what do you think? Yeah, so this is going to be a grade 3. It's not completely sequestered. If it were sequestered, what we would see is like purple fluid kind of traveling down the actual spinal cord. So I would say this is a grade 3 disc pathology. And then this is just another example of an L5S1 herniation. And what do you see here most often? Yeah, so if you look at that, it actually looks like it's sequestered. You see how the fluid is starting to move up the spinal cord. So this would be an example of a sequestered lumbar disc herniation. All right, I've talked a lot about neck flexion, right? And I've talked a lot about how that increases load kind of on the lumbar spine. So I'm giving you some stats now. Flexion increases disc pressure by 50%, seated flexion by 80%. So If you're standing erect, you're looking at that and you're going, okay, 100%. But then as we start to flex, you can see that the disc pressure will increase by 100%. The discs are, they are in a position to handle the load that is being distributed in a normal standing posture, right? That's the way that we're created. They're used to some sort of load coming from the upper extremity, right? What they're not used to is when we flex, we can see that the amount of load on those discs actually increases. And then as we sit and we flex, it goes up by 80%. Laying is great, right? Laying, there's very little pressure on the disc, but we can't lay for the rest of our life. So what am I saying to you all? As you start thinking about working with patients who have disc pathologies, probably maybe want to avoid some flexion moments early on, because what we see is as we increase flexion, we're going to increase the pressure on the disc. And so anytime we have a patient with a disc herniation of some sort, we want to make sure we're avoiding the flexion exercises. Most often, patients will be prescribed extension exercises to begin with. So in terms of neurologic testing, we'll do this in lab, is we want to go through a full lower quarter screen. I know this slide says L4, L5, S1, but that's just because those are the nerve roots that are most susceptible to actual herniation. So L4, L5, L5, S1, those are going to be the common 2 nerve root levels, but you certainly should start a lower quarter screen with L1 and work your way all the way down to S2 just to confirm and to make sure you're doing a very thorough assessment. So 98%. Of disc herniations in factor L4, L5, L5, S1. But again, I want to make sure that we're all on the same page. You should start at L1 with your lower quarter screen just to be. So now we're moving into extension-based exercises, a group of pathologies that we'll spend time discussing, not first, but that we'll spend time discussing are spondylopathies. What you see here is a gymnast, and the reason you see gymnasts here is because they spend a lot of time in extension moments, which is what we're getting ready to talk about, our extension pathologies. The first pathology that I wanted to talk about is a Facet Syndrome. So think about the lumbar facets. I love what their role is in the human body. They give the lumbar spine a lot of their rigidity, and their major role is to protect the intervertebral disc against rotational injuries, right? So they're like the first line of defense in a rotational kind of injury. Then after that, the disc will also give way. So they play a major role in stability, but they also play a major role in really protecting the disc, right? Oftentimes what we see is that facet joint pathology just in general is closely linked to pathology in some other spinal components. So an example would be if a patient presents to us with degenerative changes or degenerative disc disease, for example, that will increase the amount of workload for the facets, right? Because now the disc can't do what it's supposed to do, which is absorb shock. And so something else within the spine most often does. And that typically is the facet, right? So it's going to alter the way at which forces are distributed. And most often those forces get redistributed to the facet joint itself. So as we think about how it can actually happen, we're in the extension group of pathologies. Acute would be forced extension with a hyperrotation, and then chronic would be repetitive extension. So the gymnast, for example, who spends a lot of time in back bending exercises, or just a true hyperlordosis about the actual lumbar spine, will increase the torsional effect about the facet joint itself. So when we think about signs and symptoms of a Facet Syndrome, those patients are going to have pain with extension and rotation and will have a positive, what we call is quadrant. With the quadrant test, the patient can be standing or seated depending on their signs and symptoms. So if they have lots of signs and symptoms with standing, then seat them. But essentially what you're going to do is either in a standing or seated position, the patient is going to extend the spine and then they will rotate and they will report pain in the facet joint region. So facet joint syndrome, for the most part, is pretty harmless. The only time that it really becomes an issue is when you have a patient who has to spend a lot of time in extension moments. So treatment for that can be like a cortisone injection into the spine, unloading the patient. Remember, I talked a little bit about the concept of side lying, right? So if you have the patient lie on the opposite side and put a pillow in between there, you'll open up the facet joints, but most often direct cortisone injection or anti-inflammatory medications typically will do the trick. Okay, moving on to spondylopathies. I think that we'll probably spend a lot of time here. The spondylopathies have 3 really different levels to them. You see them here on the slide. But before I even start about just talking about spondylopathies in general, as the catch-all term is they are like bony disorders the posterior aspects of the spinal column, most often the lamina, but certainly could be the pedicles. We see these most often in sports that require repetitive extension moments. So your football linemen, your gymnasts, your swimmers or your divers and your cheerleaders, those are going to be like the top 5 sports where you'll see these pathologies be present. Lumbar spondylitic defects are rarely caused by acute trauma. So what am I saying to you? This is going to be a patient who's had microtrauma after microtrauma after microtrauma and is now coming to you. So hopefully that makes a little bit of sense. To define them, though, and to get you ready for your exam, there is spondylosis, which is a degeneration, right? We think of alosis, we think of degeneration. There's spondylolysis, which is a fracture to the pars interarticularis, which is located, so you can see it kind of here. It's going to be located on that lamina, so you have a fracture of the lamina, essentially. You have a spondylolisthesis, which is a bilateral fracture of the pars interarticularis. So you have bilateral side fractures, and so then that vertebral body is allowed to slide forward or anterior. The prevalence, about 5% of low back pain, but up to 45% of adolescents with low back pain will have one of these spondylopathies, right? So we're moving to spondylolysis and not spondylolysis versus spondylosis, because this is most often seen in patients above the age of 50 or between the ages of 50 and 60. So we won't be working with that patient population very often. We're going to skip that and we're just going to start with spondylolysis. So spondylolysis, congenital anomaly, typically to the pars interarticularis. So you can be born that way, but most often it's repetitive extension, which causes a degeneration and then a fracturing right here in that kind of laminal area. The pathology is already talked about that, but a degenerative fracture at the pars interarticularis. And the signs and symptoms of a spondylolysis are going to be very regional. They're going to be very localized low back pain. So localized, there's no radiculopathy. Are you all seeing that there? And the biggest thing is the patient will not want to go into spinal extension. So they will have a positive, what we call as a single leg stork stance, which is different than the quadrant test that we just discussed on the previous slide. In this instance, the patient is going to be standing on a single limb, and then you're going to have the patient extend the spine and see if there is pain there. So there is a little bit of difference. Next is the spondylolisthesis. Again, very microtrauma based, can be a postural anomaly which causes that. So anything that would load the spine. So hyperlordosis might be an example of that. It's rarely as a result of a direct blow. So everything that we're talking about right now is going to be very chronic in nature. In this instance, the patient's going to have that bilateral fracture of the pars interarticularis. And so you either get a subluxation or a true luxation of the vertebral body. And typically that's on L5S1 or L5. So we get this slippage. And so what are the signs and symptoms? Your patient might have what we call is a lower cross syndrome, right? And we can kind of see that here where we have weakness, remember, on either the anterior or posterior side, which causes a pelvic rotation, right? Most often that's an anterior pelvic rotation, which would cause a hyperlordosis. They'll have a step-off deformity. So because the vertebral body has displaced anterior, when you go to palpate the spinous process, it won't be present. And then they will have what we call is a Scotty dog fracture. So let's see if we can see that on the slide. So here is where we see slippage. And then right in here, you'll see the slippage or the sliding of L5 nerve or L5 vertebral body. Another way to look at this, if you're actually going to be a physician or physician assistant, is with something called the Meyerding scale, which essentially just breaks down the slip or the displacement into percents of the slip. So a grade 1 would be that 25% of the vertebral body has slipped forward. Grade 2 would be that 50% of the vertebral body has slipped forward. A grade 3 would be 75%, and then you would have 100% disruption and 100% of the body has kind of slipped forward. You can also have a grade 5, which is where the vertebral body has completely fallen off. So it's not depicted here per se, but just imagine there's no contact with the sacrum, so it's sitting completely 100% anterior. So that's just a scale that would be good for you to know, but certainly don't have to know. So how do we manage these patients? If a patient comes in and has that positive kind of stork stance, then we're going to order a bone scan if the pain has lasted between 3 and 6 weeks, and then we're going to brace them. And so there's this extension brace, which is just terrible to wear because they cannot get into an extension moment at all. but it is what most often we have to use to prevent extension moments and to prevent large extension forces from occurring, so that the spondy doesn't displace anteriorly. What we want to look at is patients who have hyperlordosis. We want to correct the hyperlordosis by doing a lot of lumbopelvic hip stabilizing exercises, right? Teach them pelvic neutral, core strengths, abs, obliques, lumbar extensors, all of those things, all of the things that come across the lumbopelvic hip complex. We actually want to work on them. And then we want to increase flexibility of the hip flexors, right, which will pull the pelvis into an anterior position, increasing lordotic curve. So we want to increase flexibility of the hip flexors and hamstrings where needed. Now, there is this thing called Williams therapy, and Williams therapy really just a set of flexion exercises which focus on placing the lumbar spine in a flex position to reduce the amount of excessive lumbar lordotic stresses that will occur. The goal of the Williams flexion exercises really is to kind of strengthen the abdominal, gluteal, and quadriceps muscles to stretch those overly active muscles that might be pulling the lumbar spine into a lordotic moment. As we progress, we're just talking about a true vertebral body fracture or a luxation of the vertebral body. So most often, if we have a fracture of the vertebral body, which is rare, most often it's caused by some type of axial load, some type of hyperflexion rotation moment, and maybe even a blunt trauma. Again, we're talking like, maybe a gunshot wound or a knife wound, for example. We can see a few things here. We can see how this vertebral body, how it's been fractured, and also it looks like it's moved or displaced and is compressing on the actual spinal cord itself. I think that where we see it most often is in that hyperflexion rotation moment, right? We know that the ALL limits extension, and then we know that the PLL will be responsible for limiting flexion. So oftentimes if you're allowed to hyperflex, there's compromise to the PLL. So that's typically a reason why. In terms of signs and symptoms, if it's in the cervical spine, they'll have pain in the chest, cervical spine, and extremity pain. And that would make sense, right? Depending on the level of the actual fracture itself, it's going to impact all of the spines, both cervical, thoracic. So the spines above it. Anesthesia, paresthesia, and weakness in the trunk and limbs most often. They may actually have paralysis depending on the level of fracture and luxation and loss of bladder control if it occurs and impinges on the quad equina. They will be point tender in the area of the fracture, may have a step-off deformity, but one of the key things is they're going to have a lot of spasm around the fractured or luxated site. So palpation will be key in those particular patients. So here is an example of a compression fracture. You can see a through and through fracture here. You can also see a fracture piece here. Interestingly enough, this happens to be a Point Loma alum, dove off the bridge in the Grand Canyon into the Colorado River. Instead of pencil diving, he hit his tailbone. So you can see right here, we have fractures, right? And so with that, we can see that there's probably going to be pressure on the nerve roots, which would cause paralysis, for example. All right, so as we move forward, one disease that we should talk about is Sherman's disease. This disease is most often known as Sherman's disease, Sherman's kyphosis, or juvenile kyphosis, and most often is a diagnostic disease that occurs early on in juvenile age, between the ages of like 12 and 16. Essentially, it's just a condition of hyperkyphosis that involves the vertebral bodies and the disc of the spine being kind of wedged against one another anteriorly, creating a hyperkyphotic moment, which we know in any patient most often can cause forward neck bending. But as you can see in this image, depending on the amount of hyperkyphosis, it can start to impinge on the internal organs. And so if it's in juvenile and if it's progressive, essentially what they'll have to do is surgically go in, and you can see it here, straighten out that kyphotic curve so that it doesn't impinge upon the internal organs of the body. The next pathology we're going to talk about is scoliosis. We can see that here. It's a lateral bending of the spine, so a frontal plane movement of the spine. It can occur in the transverse plane, but most often we see it in the frontal planes. We can see that for the most part, scoliosis can be, very harmless. However, if the percent of scoliotic curve increases, just like with Sherman's disease, we can start to see impingement on the internal organs. This is in very drastic cases. But what we know about scoliosis, it can be structural or functional, right? Non-structural, typically it's from like a leg length discrepancy or some type of muscle spasm or contracture, and that's reversible, right? Anytime we have a leg length discrepancy, we can fix that. Anytime we have a muscle spasm, maybe causing changes in the actual curvature of the spine, we can reverse that. Structural, on the other hand, is rigid and it's fixed. And oftentimes it's a congenital defect that develops during development. We see this most often like when student athletes just all of a sudden they're like 4 foot tall and they come back and they're 6 feet tall. So typically it can be growth related, and it will need some type of brace. Like when I talk about a brace, I'm talking like a corset to kind of control the progression. So 80% of scoliotic cases are idiopathic, some sort of genetic predisposition. So we don't know why it often occurs. So you're going to have to, in your history questions, ask about family history, whether or not there are parents or siblings who have a scoliosis. Typically, it's usually diagnosed at about 10 to 15. So right after that growth spurt that I just talked about, a 35-degree curve or greater is a referral, and anything that is greater than 50 degrees in terms of curve, because it's going to start to impinge on those internal organs, is actually surgery. So they'll have to go in, straighten the spine, and fixate as well. Unfortunately, girls, you're more likely to develop, you're 10 times more likely to develop this than your actual male counterpart. So how do we assess for this? We talked about it in the clinical setting. We're going to do that Adams forward bend test for scoliosis. If the curve remains, it's structural. If the curve relieves, it's going to be functional. So here is a diagnostic tool. And then we can see that this was the image before where you saw that massive curve. And now you can see the image of the patient in the actual brace. So you can see how that brace really, really, truly does impact the curvature. Let me go back 2 slides. So here's that patient without the brace. And then here's that patient with the brace. So we can see that bracing a patient is extremely important. So all in all, when we have a low back pain patient, the question is like, when do we refer them? When is it out of our control? And that's typically the question that I have. So refer to a neurosurgeon or orthopedic specializing in back surgery if the signs and symptoms are progressive and severe, and the patient presents with some sort of neurological deficit. You're going to pick up the neurological deficit in your lower quarter screen most often, right? If the neuromotor deficit that persists after 4 to 6 weeks of conservative therapy, right? Because we're kind of moving out of that subacute and we're progressing to kind of we're getting ready to progress into the chronic low back pain. So anytime you have a neuromotor deficit, whether that is a decline in a myotomal or domotomal assessment or even reflex assessment, and you've continued to do the right conservative therapy for 4 to 6 weeks and the patient isn't getting better, we're referring out. The patient presents with persistent sciatica, a sensory defect, deficit, or reflex loss after 4 to 6 weeks, we're referring out. Again, this is all assuming consistent clinical findings, that we've checked their mental health status, right? All of those things, because remember, they determine the progress of the rehab in a patient with low back pain. Non-orthopedic referral. So suspected spinal cord compression with neurological deficits in a patient with cancer and risk of spinal metastases. Well, we're not referring that to ortho, right? We're going to refer that to their primary care physician. Quad-Equinus syndrome typically features bowel and bladder dysfunction. So we're going to refer them again to their primary care physician, and most often a urologist as well. So all of this to say, I want to thank you for listening. We're going to go through some evidence-based articles in class, which will also kind of help drive home our treatment decision making. But for now, this concludes the lecture on the pathologies that can occur to the spine.